Hello, everyone. Welcome to our Albinism Awareness Series, a joint effort between the ILDS, the GLODERM Trainee Committee, and the Global Albinism Alliance. My name is Akash Varma. I'm the current chair of the GLODERM Trainee Committee, and our co-host today is Antoine Glickson, the executive director of the Global Albinism Alliance.
Welcome, everyone. So we will have 4 different sessions in this webinar series. We will first cover genetics, then dermatology, then we will have a webinar on ophthalmology, and finally, a last webinar addressing the social impacts of albinism.
And all of these webinars will have additional live Q&A time. So as I mentioned, your hosts today are me, Akash Varma, and Antoine Glickson. So I just want to give you a little information about the organizations which we represent. GLODERM is the International Alliance for Global Health Dermatology, and it's an official program of the International Foundation for Dermatology under the International League of Dermatologic Societies. The mission for GLODERM is to improve skin health for everyone everywhere by connecting dermatologists and trainees who are dedicated to improving skin health for all in resource-limited communities locally and globally. I represent the GLODERM Trainee Committee, and our main mission is to make sure that we disseminate information to individuals all over the world and increase education for dermatologist training in all settings.
And as mentioned before, my name is Antoine Glickson. I'm the executive director of the Global Albinism Alliance. The Global Albinism Alliance is a young international NGO that was launched about 4 years ago in 2020. Today, we represent about 250 associations and other NGOs that are serving the albinism community in all regions of the world. The mission of the GA is structured around 3 main pillars. We exist first to support albinism organizations that operate around the world. We act also to improve knowledge about albinism. And finally, we are the voice of the albinism community at the global level. And in that frame, we advocate to improve and protect the rights of persons with albinism at that level.
Great. So just to run over some etiquette for today's webinar, if you have any questions or comments, please submit them via the chat function. Our speakers will answer your questions at the end of the webinar. And we will be sharing further information about the GLODERM Trainee Committee and the Global Albinism Alliance in the webinar chat, so please be on the lookout for that.
Before we start, I'd like to remind you that this webinar series is put together and offered to you as a way to celebrate International Albinism Awareness Day, which has been celebrated since 2015 every year on June 13th. Hi, everyone. Welcome to this third session of our webinar series. Today, we are going to address the visual aspect of albinism. As many of you may know, albinism is a condition that affects the skin. It's most of the time highly visible, but albinism is also a condition that affects the eyes of an individual. We have today 2 outstanding speakers who will cover this topic. One will cover ophthalmology at the global level, and the other one will more specifically address the challenges of managing a person with albinism in a low and middle resource context. We are thrilled today to have Dr. Mervyn Thomas, a distinguished ophthalmologist and genomic medicine expert who completed his medical degree and PhD at the University of Leicester, UK. As an NIHR clinical lecturer, his research focuses on foveal development and nystagmus, contributing significantly to diagnostic and classification tools and clinical guidelines. Dr. Thomas is also a key member of several prestigious research groups and advisory boards, including the Genomics England Clinical Interpretation Partnership and the Nystagmus Network. Over to you, Dr. Thomas.
Hello everyone, my name is Mervyn Thomas. I'm a clinician scientist and ophthalmologist based at the University of Leicester in the UK. It's my privilege today to speak to you about albinism from an ophthalmologist perspective. In this talk, I will cover the ocular phenotypic spectrum and recommended examination techniques that should be used to elicit some of these findings, differential diagnoses to consider, the value of prognostication, and finally an approach to management. Albinism is a hypopigmentary disorder which is both genetically and phenotypically heterogeneous. It is not uncommon for children with albinism to initially present to an ophthalmologist due to infantile nystagmus or reduced visual acuity, strabismus, or anomalous head posture. Interestingly, melanin is seen in various structures within the eye, and the lack of melanin, which causes hypopigmentation, can present within the iris as transillumination defects. Similarly, in the retina, the lack of melanin within the retinal pigment epithelium or the choroid can be shown as fundus hypopigmentation. Some of the consequences of this include arrested retinal development or foveal hypoplasia. The optic nerve can also be abnormal, and there can be also retinal ganglion cell misrouting or the axons at the optic chiasm. Refractive error is also very common in these, and we will discuss some of these characteristics one at a time. These are some examples of iris transillumination defects which can be graded based on the severity. For example, image 1 shows the least amount of iris transillumination, whilst image 4 depicts total iris transillumination, where you can actually see the outer part of the lens. This video depicts a patient with albinism. You can certainly observe the nystagmus and the technique of iris transillumination, whereby light is shown through the pupil and then it's retroilluminated from the retina, and there you can see where there are defects within the iris which transilluminate. Refractive errors are common in albinism. In European populations, hypermetropia tends to be more common, and high levels of astigmatism with the rule astigmatism tend to be seen in albinism. The lack of melanin within the retinal pigment epithelium and the choroid can be seen on fundus examination as fundus hypopigmentation, and this can be graded based on the severity and extent of involvement. For instance, in grade 0, there's no fundus hypopigmentation. In grade 1, it's just the posterior pole surrounding areas of the optic disc. In grade 2, on the other hand, you have it in the mid-periphery, and finally in grade 3, where there's complete hypopigmentation, including that of the macula. A characteristic phenotype seen in albinism is foveal hypoplasia or arrested foveal development. To understand this better, it is helpful to revisit the developmental biology and events that take place that result in the formation of the fovea. So at fetal week 10, we have a retinal lamination pattern. So in this first panel in figure A, which shows the different cellular layers of the retina. By about mid-gestation, a foveal pit starts forming, and soon after birth, we have the centripetal migration of these cone photoreceptors, as well as these outer segments of these photoreceptors gets long and thin, allowing increased packing of these cone photoreceptors, resulting in this area of high acuity. And the pit also gets deeper and wider, and that results in this formation of this fovea. Fovea is just a Latin term for a pit. Each of these developmental events, which is the centrifugal displacement of the inner retinal layers, centripetal migration of cone photoreceptors, and cone specialization, has an equivalent OCT or optical coherence tomography feature. Therefore, we can create a grading system that allows us to grade different levels of foveal development depending on the loss of each of these specialization events. For instance, in grade 4 foveal hypoplasia, you have complete loss of all specialization features and what looks like a peripheral retina. On the other hand, in grade 1 foveal hypoplasia, you have a rudimentary pit, you have inner retinal layers just posterior to the fovea, and some of those specialization features are still present. And understandably, the ones with the better prognosis tend to be ones with grade 1 foveal hypoplasia, as opposed to grade 4, which tends to have the worst prognosis. The way we visualize this is using a technique that I alluded to earlier called optical coherence tomography, which might be available at a high street opticians or within a hospital itself. Now, in adults, this is quite easy to image because they are head stabilized and table mounted OCT is quite easily possible. On the other hand, in children, this can be challenging because you have to get the child to the machine. And this is an example of what is referred to as a flying baby position, which can be quite distressing both for the child and the parent, but also for the operator of the instrument. And as you can see, there's multiple individuals involved sometimes in this scenario. Now, handheld OCT is a technique whereby we can bring the machine to the actual child to allow detailed visualization of the retina, both in a clinic but also in a ward setting. And this in turn has really helped in terms of the practice within both infantile nystagmus, but also diagnosing foveal hypoplasia or other retinal defects. This is an example of a video showing a demonstration of the handheld OCT technique, whereby the handheld probe, which looks like a hairdryer, is brought close to the eye, and within a few seconds you can acquire images in a non-invasive manner. Normally, about 53% of the total optic nerve fibers decussate at the optic chiasm. These are your nasal hemiretina fibers that cross over to the contralateral hemisphere, whilst the temporal hemiretinal fibers go to the ipsilateral hemisphere. In albinism, what can happen is a bulk of your temporal fibers also decussate, resulting in excessive crossing at the optic chiasm. This is often detected using a technique called visual evoked potentials, and this is an example of a video showing this, where a checkered pattern is shown and different electrodes are placed within the scalp, and responses to those stimuli are recorded. And excessive crossing is shown by VEP asymmetry or visual evoked potential asymmetry, and this is just an example shown in a patient with infantile nystagmus, idiopathic infantile nystagmus, compared to one with albinism on monocular stimulation. Infantile nystagmus is a common reason children with albinism present to clinics, ophthalmology clinics. This is an example of a child with albinism having bilateral conjugate, meaning the eyes moving together, horizontal nystagmus. In addition to that, you can see that the skin, eyebrows and eyelashes are hyperpigmented. Bilateral horizontal conjugate movements of the eyes tend to be the most common, the form of nystagmus we see in patients with albinism. However, we can get atypical presentations like this, where you get this rotary or torsional nystagmus in this particular individual with TYR mutations. What's interesting in this particular case is also that they had an infantile esotropia, which can be associated and seen in albinism. They can have this inferior oblique overaction as well as dissociated vertical deviation. The nystagmus, because of the torsional nature, we did perform MRI scans because it tends to be an atypical form of presentation in albinism. But this again goes to show the wide phenotypic spectrum we observe. On fundus examination, we can see that they had hypopigmentation of the fundus, and OCT reveals that there is foveal hypoplasia. These are investigative modalities one might consider when dealing with a person with albinism. For instance, optical coherence tomography helps us identify that critical sign of foveal hypoplasia seen in albinism, but it's also seen in a number of other differentials which one must consider. Eye movement recordings are helpful, the most common being that horizontal bilateral conjugate movement of the eyes with an increasing slow phase velocity. But again, there are a few differentials that you should consider when seeing such a waveform. Visual evoked potentials are particularly useful because your differentials start to narrow down quite significantly. So if you see an asymmetric response on VEP, it often signifies either one of two diagnoses, which is albinism, or F-Honda, which is foveal hypoplasia, optic nerve decussation defects with or without anterior segment dysgenesis. Finally, genetic testing allows you to really narrow it down to the exact gene involved, and identifying pathogenic variants can really help solve your diagnostic dilemmas. Because OCT is becoming more readily available, We also developed an OCT-based approach for differential, so because the starting point might be from a clinic where you see abnormal lamination or outer retinal disruption. If that's the case, we often consider this tend to be inherited retinal dystrophies, and our investigations therefore are targeted towards doing either gene panels for those retinal diseases or for doing electrophysiology called electroretinograms. On the other hand, if we see foveal hyperplasia, which is characterized by the hallmark of this continuation of inner retinal layers just behind that foveal pit, that signifies that there is foveal hyperplasia, and one could consider doing a gene panel test looking for genes involved in foveal hyperplasia, which includes albinism. However, the lag time with a genetic test can be significant, so one may consider doing a VEP testing, which is looking for that misrouting or asymmetric response on the VEP. If that is present, then the differentials tend to be quite narrow, and whether or not there is hypopigmentation further divides it into SLC38A8 mutations which don't have hypopigmentation, and that SLC38A8 mutations causes F Honda, which I was alluding to earlier. On the other hand, if there is hypopigmentation, one should consider albinism. Now, as medics, we tend to love grading systems, and in the UK there are a number of cities that are famous for grading systems, and this includes Bristol is famous for its stool chart. Glasgow is famous for its coma scale, Glasgow coma scale, and finally our claim to fame in Leicester is we have the grading system for foveal hyperplasia, which I alluded to earlier. We use this quite routinely within our clinics, and it really helps narrow our differentials quite significantly based on the pattern of foveal development we observe. Now, because foveal hyperplasia is a rare disease and we don't know the full spectrum of it, we developed this foveal development investigator group, which consisted of 20 centers across 12 countries, and we put together our cohorts of patients with foveal hyperplasia to see whether there are any patterns that we observe. What was really interesting is that we found these very striking patterns of foveal developmental defects we see. For example, in Hermansky-Pudlak syndrome and ocular albinism, which is due to GPR143 mutations, we only observe grade 3 and grade 4 foveal hyperplasia. Whereas in OCA, non-syndromic forms, oculocutaneous albinism, we find the full spectrum from grade 1 all the way to grade 4. Similarly, the other big differential we often consider when we see foveal hyperplasia is PAC6 mutations or SLC38A8 variants, which causes that F Honda that I alluded to earlier. Now again, we get a very restrictive or narrow phenotypic spectrum with SLC38A8 variants. So these help us and give us clues as to what is going on. In terms of visual acuity, what we found was that this corresponds with the phenotypic spectrum we're seeing. So for example, both with HPS, Hermansky-Pudlak syndrome, and ocular albinism, we find that their vision tends to be worse when we consider the entire spectrum of the OCA group. Similarly, when we look at across the different causes of infantile nystagmus, FRMD7 unsurprisingly tends to have the best visual acuity, and they tend to have either normal foveal morphology or in some rare instances grade 1 foveal hyperplasia. When we look at the grades of foveal hyperplasia against the visual acuity, we see this really nice logical progression, with grade 1 having the best visual acuity and grade 4 having the worst visual acuity. So these were done in adults. Now what we wanted to do is, can we prognosticate in children? So this is in proverbial children. Before we can get a reliable visual acuity, can we do a scan to determine the foveal morphology and predict what their vision is 5 years down the line? And indeed what we found was that actually the foveal morphology scan very early on in proverbial children can predict their future vision, as shown here. Albinism is a clinical diagnosis, and therefore you require a constellation of signs, symptoms, and investigative features before deciding whether or not a person has albinism. There are some diagnostic criteria that have been proposed which can be helpful in a clinical setting, and these include major criteria, for example, higher grades of foveal hyperplasia more than 2, misrouting on BEP, or ocular hyperpigmentation as described previously during the phenotypic spectrum, such as iris transillumination defects or fundus hyperpigmentation. Minor criteria include nystagmus and lower grades of fundus hyperpigmentation or foveal hyperplasia. Now, if there is a molecular confirmation of albinism based on genetic testing, it helps and it simplifies the process, but it needs to be interpreted in the context of the phenotype. So there needs to be at least one major or two minor criteria. Similarly, if there is no access to genetics, one could just use a constellation of these signs to put together a diagnosis of albinism. Most often, patients present with infantile nystagmus, and there can be a wide range of differentials that cause this, including more sinister causes of nystagmus, which may or may not warrant some more invasive investigation, such as MRI under anesthesia. But with the advent of genetic sequencing, certainly one can make the case for using it as a frontline diagnostic tool, which may well obviate the need for this battery of investigations. Nevertheless, we have to put it together with the phenotype to finally come up with the diagnosis, and there are various diagnostic pathways that have been proposed as a result of this. Unfortunately, there are currently no curative treatments for albinism, although this is an active area of interest and lots of researchers working towards potential therapies. Most of the treatment is aimed at supportive therapies to optimize the vision. These include correcting refractive error using contact lenses or spectacles. You can also consider low vision aids. Nystagmus can sometimes be treated using pharmacological therapies, and there have been randomized controlled trials showing potential use of gabapentin and memantine. Similarly, if there is an anomalous head posture or an eccentric null position refers to the quietest point within the orbit where nystagmus is the quietest. So shifting the null point centrally helps correct the anomalous head posture, and the procedure is called an Anderson-Kestenbaum procedure. Similarly, glare tends to be another complaint that people suffer from, and using tinted glasses or contact lenses. Similarly, simple methodologies such as just using a hat with a brim may help reduce some of the overhead glare. Beyond vision rehabilitation and supportive measures, other considerations include things like genetic counseling. It's important to know the inheritance patterns and subsequent family planning. Needless to say, skin protection is highly important and relevant. Educational support, and finally, let's not forget surveillance, both from a skin but also an eye perspective, reducing the risk of developing amblyopia and consequences of poor vision management. So in conclusion, I hope I've been able to give you an overview of the phenotypic spectrum, ocular phenotypic spectrum seen in albinism, how we perform some of these investigations, how we go about distilling some of these differential diagnoses, what we can do to prognosticate, in particular in preverbal children. The OCT has a key role in prognostication, some of the diagnostic criteria we use when we put together these constellation of signs and symptoms, and finally an approach to management. For any of you wanting to read more or learn more about albinism, we put together this NIH commissioned resource known as Gene Reviews, together with dermatologists as well as clinical geneticists and ophthalmologists. There's a wealth of information here that's available if you're interested to read further. I want to just take this opportunity also to acknowledge the tireless efforts of the Leicester team, the Ulverscroft Eye Unit, as well as the hospital department, which is the ophthalmology department and orthoptic team at the Leicester Royal Infirmary, and our collaborators across the globe that have contributed towards a wealth of knowledge in albinism. Last but not least, our funding bodies that have supported research in albinism over the years. Thank you all for listening, and if you want to get in touch with me or want to chat more about albinism, please feel free to drop me an email. Thanks once again.
I'm now delighted to introduce Dr. Becky Kammer, a seasoned low vision specialist with over 20 years of experience. Currently serving as the Vice President of Clinical and Medical Affairs at Samsara Vision, she has recently focused on clinical trial research for retinal diseases. Dr. Kammer has also led efforts in East Africa for 13 years, providing low vision care to individuals with albinism in collaboration with organizations like Standing Voice and Under the Same Sun. Over to you, Dr. Kammer.
Hi, my name is Rebecca Kammer. I am an optometrist from USA, California specifically, and I also have a PhD. I have been a low vision rehabilitation clinician for about 20 years, and in the last 6 or 7 years, I've transitioned more into research, clinical research, working with clinical trials and retinal diseases, and trying to find solutions, treatments, and I design assessments that help determine whether those treatments are effective. But I got involved in albinism many years ago, about 13 years ago, and specifically my lecture today is about more of a global south perspective. So most of my work is in East Africa and then some in South Africa. And so some of the things I'm going to share today are from a program that I've had there for about 13 years. I have worked with Under the Same Sun was the group, the nonprofit from Canada that I first started with about 13 years ago. And then I started working with Standing Voice from the UK shortly after that. And I'm the director of low vision services for Standing Voice. You can look at standingvoice.org. We have a vision and a skin cancer prevention program along with advocacy and so on. Under the Same Sun is also doing some amazing advocacy work globally. And occasionally I will be an advisor for them in terms of vision and low vision rehabilitation. These pictures here are actually from some of my first trips. In the upper right is me trying to do retinoscopy on a child who was not very excited about it. Retinoscopy is a very important tool. I'll talk about that in just a little bit. But it does help me to determine what the prescription is without the child ever having to say anything. So that's very important. And then the young man looking on was a medical student who wanted to go into ophthalmology. So he was coming to the clinic to observe and learn. And then in the lower picture is one of my first groups of optometrists that I trained in Tanzania. I believe it was 10 people, and an amazing experience. So although I started going there to serve and to provide low vision services, shortly after I was able to transition that to training others to do the care and to spread that knowledge and to grow together and learn together in patterns and see how we could expand our work really across the country where we were working in, which was Tanzania. So let me go through a little bit of difference between oculocutaneous albinism in Africa versus in USA. So my clinical work, I've been in academia, I've had departments for low vision rehabilitation. And when I've been in US, I've had patients with albinism, but very few patients. They're quite a bit more, the prevalence, or it's not very common in the US, so maybe 1 in 20,000 is some of the numbers, whereas in Africa, and especially East Africa, is actually quite common, much more so, maybe 10 times more common, so ranges from 1 in 1,400 to 1 in 4,000. And they're a little bit different types, so there's other lectures that will talk about different types of albinism. Today I'm going to focus primarily on type 2, which does have some pigmentation, so not completely without pigmentation. So that means that the oculocutaneous part of skin, hair, and eyes, it's a misnomer to say ocular albinism. There is a type of ocular albinism where it only affects the eyes, but normally you wouldn't know that because skin color looks the same and hair color is the same, has full pigment. So often optometrists or ophthalmologists will use that term, and I just want to correct that, and it's oculocutaneous albinism. So in Africa, it's primarily type 2, and there was discovered a particular mutation in a P gene many years ago in the region of Tanzania. Um, albinism, oculocutaneous albinism. Ocular albinism is actually a different type of genetic pattern, but the autosomal recessive I'm going to talk about today, more about these type 2 and type 1, is where both parents, appear that they have full pigmentation. You wouldn't know it. They don't have albinism, but then they have a child with albinism. So that's quite shocking in dark-skinned Africans in East Africa when they have a white child or a light child, of course. And so with that, because there's not a lot of awareness about the genetics and that most parents actually have this gene and contribute to this, there's often a lot of blame on the mother for having this child that looks so different. And then there's a lot of different myths and false beliefs about it. So that's really led to some horrendous things in East Africa, just with attacks on children, murders, and really a trafficking of body parts within kind of witchcraft and so on. That's gotten better over the years, but is still there, and so we have to always be careful of it and really, work for advocacy and educating all those that really this affects, whether it's a person with albinism or the society around them. So I got involved because I really wanted to help make a difference. And I thought, well, if I impact vision, then hopefully vision can impact education. Education can impact employment and social inclusion. And that is true to a large degree. It's very important to have vision and be able to succeed in school and not drop out quickly. Back to the USA, we have different types there, type 1 or type 2, where type 1 is really no melanin. And so you have a picture down here on the right of a young lady who doesn't have any, and she has really white hair, very light blue eyes and irises. And whereas in the picture down the lower left, this is more of type 2, and it's going to have more of hazel colored eyes, kind of yellowish, blondish color hair. So let me remind of a few characteristics of vision and albinism. And again, this is covered in another lecture with my colleague, an ophthalmologist, who will go into some more detail around this. But in a quick kind of how do these things that, structurally are changed in someone with albinism, how do they affect kind of function and what you actually see in terms of kind of everyday characteristics. So foveal hypoplasia is really an underdevelopment of the fovea. And so as a result, your straight ahead vision, which is very important, you usually would see the highest level of details. That's just going to result in poor acuity, poor resolution, and just general blur. No real blind spots, though, which is a good thing for when you're trying to navigate and walk and so on. There's not too much impact on mobility, but there is a lot of impact on reading and seeing the chalkboard in school, watching TV, seeing faces, things that require some detail. Nystagmus also comes along with albinism, and that's often when the eyes are shaking, and typically it's a horizontal motion, but there can be different patterns of that. Sometimes your head and eye and brain will actually work to find a better point, that things are a little bit slower. They still will shake, but it's usually a little slower. It's called a null point. That might be a head tilt or a head turn, or even a position of the eyes. Commonly, I found in East Africa that holding things close, so the motion of convergence, will calm the eyes a little bit. And that can help those persons with albinism see just a little bit better, a little better quality of vision when that happens. So maybe we'll be able to try to position a child in a classroom in a certain place to kind of utilize that head position so that they can have a little calmer eye position as they're doing their classroom work. There's also some other things like decussation of optic nerve fibers. This is where just when the baby is developing in the womb, nerve fibers in the eyes don't perfectly cross the way that they should and kind of meet up in the back, where the back of the brain. And that's important for depth perception and then for both eyes to really kind of work together. And so what often happens is one eye will have a strabismus or an alternation, meaning alternating exotropia or esotropia. And that means that one eye is either in or one eye is either out, or the eyes kind of switch. But usually it means that there's not going to be both eyes really working together well to have very good depth perception. Now, there's the cues to depth. We can use cues like the size of objects to really determine how far away things are. So people can adapt very well without this depth perception, but it still is something to take into account when we're managing vision and trying to help overcome some of these things. So what this does impact, though, is often there's one eye that's dominant or preferred. Again, it could be an alternating where it's either or, but this is important when we're prescribing glasses, because if one eye is much more dominant, has maybe kind of a lesser refractive error or prescription needs, then we can prescribe to that eye and kind of let the other one work with kind of an even prescription, and that's an easy way to prescribe glasses. I'll go on and show how we do this in Africa, where we have got to provide a lot of glasses to a lot of people, and then don't have a lot of time or money to be able to provide very customized glasses for each person. The iris defects and the coloration of the back of the eye, the retina, both of those cause light sensitivity, photophobia, and so it really needs some sunglasses to help with that comfort, and also just to protect it against ultraviolet rays, as ultraviolet can do some damage to the eyes, and if we don't have pigment to absorb that, that can be problematic in the long run. So wearing sunglasses is important. And then there's often high refractive error, and this can come from our brain and eyes normal development. We usually, create a certain emmetropia, let's say, so you don't need glasses, your eye is the right length, and so on. Now, of course, we know a lot of people that need just small prescriptions and so on, but often in albinism or in certain other diseases from childhood, eye diseases, where we don't kind of have that control mechanism, sometimes the eye will grow quite long or it'll be short, and it just doesn't have this feedback to tell it, okay, stop growing so much. So in East Africa, a lot of the work I was doing, I found a lot of myopia, nearsightedness, whereas in the US, it's much more hyperopia and farsightedness, along with astigmatism. And I'll talk a little more about that in a little bit. So as I mentioned, there's these barriers in Tanzania specifically, just culturally, and there are different social stigmas in different parts of the world, depending on how people receive albinism or understand it or interpret it. But in that part of the world, again, it was just a lot of atrocities were going on and a lot of social isolation, and these kids are really in danger. So our vision programs were supportive of trying to ultimately help children and persons with albinism integrate in society and have their rightful place with others. So our vision clinics initially, when I started, it was around 2012 or so, and we started our first vision clinic, and it was basically in a classroom, dirt floors, and tried to cover some of the windows up, and we did some very basic eye exams, more focused on refractive and how we could help with magnification and glasses. We would do these classroom clinics, and we'd really focus on the refractive exam. And so this was important to make sure that we were providing the kids with glasses in school. We would start with kids around 6 years old to 8 years old. We found that pretty soon 8 years old was a good age. Younger than that, the glasses were were broken, and they were taken by other classmates and things like that. We would hold these clinics in classrooms, kind of dirt floors and so on, very adaptable, but really focused on the refractive error, the providing of glasses and basic magnifiers. We found then this was really just high myopia that we were finding. Even children that were 8 years old would have maybe -4 prescription. And for us in the US, that's a pretty high prescription. I remember that was about mine before I even had LASIK myself, and made a world of difference. So, just wearing glasses for even -4 would make a big difference. For people with albinism, they don't see as much detail, so -4 is still very important. It's not quite as important and critical to someone who has full vision, but still very important. Slowly, program evolved over time. I would first initially bring glasses with me and set up these clinics with as many glasses as I could purchase from the US or have donated. And then over time, we built really a big inventory with standing voice. We had glasses pre-made. We partnered with others in order to get the glasses. And then I found that by looking at Excel spreadsheets and large samples of data, I was able to figure out that we could really provide these glasses in these 2 diopter steps, and we could also provide the astigmatism correction that most kids needed. Astigmatism is a little more complicated, and so we do need to get that on to children at an early age. Otherwise the brain can have some amblyopia and not adjust well to the glasses later. So that is an important consideration in prescribing, but we would create glasses that had either 2 diopters or 4 diopters, and they would have axis 180. That's a certain direction that was pretty common in albinism. Rarely was it any other direction than 180. And then we trained others on this inventory and how to prescribe these glasses so the kids could get them the same day. And then in 2016, we shifted to very large clinics. These are events where we'd have 300, 500 kids. We would rent out a much larger conference center. We would bus children in from schools all around. We would work with local albinism groups where they knew how to contact families with children with albinism, because often in societies these were children and young adults were kind of hiding away and not integrating. They were not facing a very welcoming society, and so to bring them to events was actually a really big deal at the time. But this made it more efficient, and we worked with Tanzanian optometrists where I had trained them. And we developed a partnership with Essilor, and they were providing these very expensive glasses for us, which was amazing for the kids. Our prescribing strategies, as I alluded to, when you have a kind of one eye that's more dominant, the first strategy is to figure out which eye that is. Now, if the patient doesn't know, they might say, oh, either one or this one, and then we would continue to do our exam, and we would determine which one was kind of the better eye. And often you'd have one eye that would have a certain number of prescription and the other one was maybe much worse. Well, we would prescribe to the one that has less. And even though the other eye might not be fully corrected, it might be a little blurred, the brain's ignoring that one anyway. Otherwise, it would have double vision. So we were playing into the idea that, the brain's already kind of self-selecting. So let's use that for our prescribing kit. These pictures are special to me because this is kind of a mentoring program that's going on in the first picture with other Tanzanian optometrists. And in the lower one, this is a friend of mine that was a young child when I first started, and now she's grown into a beautiful young woman. But you can see that her glasses prescription is quite high. She's up in the -20, -24 range, which isn't uncommon. So this is really this kind of malignant myopia that really does keep growing. I did have a retina clinic 1 year, and we did evaluate to see if there are retinal breaks, because the longer your eye, the more chance you have of retinal detachments. And we did find 1 or 2 cases out of about 300, but we didn't find it in, high rates. Now, at the time that I was doing these clinics, people actually didn't live past about 40 years old because they also had skin cancer, which is very preventable, but at the time there wasn't enough treatment for it. And so, do people with albinism have a higher risk of retinal detachment as they get older? Possibly. More studies need to understand that, but we should be careful with really just being in high impact sports or high impact things where things could hit your face if you are highly myopic, in case you do have retinal detachments or it's kind of a stretching of the eye that makes your retina more sensitive and prone to breaks. So these refractive trends, as I mentioned, I kind of mapped these out, and I found that, the younger they were, they started in these lower minus prescription ranges, but it definitely went all the way up to in the -20s at time. And then I also mapped out what was the best corrected visual acuity, and found that it was about 0.8 was the best corrected visual acuity. So in some regions, there's different ways of representing vision. And 20, that would equate to about 2120. So I found if someone was around 2300, I could usually get them corrected down to 2120. If they were much worse than that because they were a -20 diopter myope and hadn't have glasses on, then maybe they were off the chart. So getting glasses really mattered to those patients. And really, it turned out about 40% of people really needed strong glasses. So, if I had a school of 100 classroom of 100 kids, 40 of those kids really would need strong glasses. So we don't want to just assume that glasses don't matter or don't help in albinism. That's not necessarily true at all. As I mentioned, astigmatism is a common thing. It's a little less common in this group in East Africa, but in the US, we would find astigmatism quite often and more farsighted type. As I mentioned, visual acuities really can improve with these glasses. And also, if you prescribe, there was a small group that had hyperopia, farsightedness with astigmatism, and they might not see a lot better with the glasses on because they're used to kind of doing the over-focusing themselves with their own eyes. Their eyes have an ability, our eyes have an ability to accommodate. Accommodation is really kind of over-focusing. But as we get older, it's harder to do that, and that's when we need reading glasses. We become presbyopic at about 40. Well, young kids can really over-focus quite easily, so it's very common for kids to hold things very close for low vision management, for them to figure out their own way of making things bigger so that they can see them better. So our low vision management strategies was really similar. How do we make things bigger? So we provided sunglasses, we dispensed the glasses, gave the glasses out the same day if possible to teach them how to use their glasses. But we also worked with monocular telescopes, and I was able to find some good resources for that to provide inexpensive telescopes. We also did some dome magnifiers at times. So the monocular telescope really worked well, and we found that about a 4x telescope worked for most everyone we needed. 3x was probably fine, but 4x really met it well. And for some really severe patients, maybe with type 1, we might need a 6x, but it was really easy to provide 4x. And I found a source that could provide them for about $12. So that was very nice, because much lower than you could get them in even the States at times. And we teach the kids how to spot with them and how to use them. And you can see they're keeping their other eye open. And that's actually pretty common, because again, the brain is only really using one eye and it's ignoring the other one. So that makes it nice. Now, if you or I were to use a telescope with just one, we'd have to probably wink the eye or close it down. So some kids might need to do that, and we have to figure out which is their better eye to use. But the monocular worked very well, and they're very quick learners. So they could use that to see things at distance, like things on their chalkboard and so on. My project in Africa took me in a lot of different exciting ventures. I've been able to write a book chapter on it. There's a book called Albinism in Africa that I would recommend if you're interested in learning more. There's quite a few topics about it, and I have a chapter in there with a co-author, and we talk about low vision rehabilitation strategies and kind of low cost strategies. I've been able to climb Mount Kilimanjaro with a group of women with albinism. There were 7 ladies from different countries, and they trained. Some of them on the way had altitude sickness and couldn't make it to the top. But there was one woman with albinism who did make it to the top, and I was honored to be there with her. So I was kind of their team eye doctor and provided sunglasses and taught some of the guides how to work with them on some of the more uneven ground and so on. But here's a picture of the one woman who did make it, and then there's me on the right. So it was a very exciting trip. So I've made a lot of wonderful friends, and it's been an amazing journey. I'll wrap up here. My email is there if you want to contact me further about anything, but thank you so much for attending the webinar and advocating for persons with albinism.
Hello, everyone. As we are now in our Q&A session, please submit any questions you may have in the webinar chat, and all speakers will answer them shortly.
Thank you, Dr. Rebecca Kammer and Dr. Mervyn for that wonderful presentation. So we go live with the Q&A. So the first question is, due to the lack of melanin in the eye, are there any concerns for malignancies?
I can perhaps start. That's quite an interesting question. So in the UK, we don't have the privilege of having very much sunshine. So right now it's June, and in fairness, it's rainy and a bit miserable, to be honest. I had to turn on my heater as well. But specifically regarding that question, I don't think we see a lot more eye malignancies per se. Perhaps with regards to adnexal malignancies, the same risk factors apply to that in terms of skin cancer, so lid-related malignancies and so on. There are certain case reports of melanomas, like amelanotic choroidal melanomas and things like that in albinism. But in clinical practice, in all honesty, I don't think in the UK we necessarily see a higher prevalence of ocular malignancies in these individuals with albinism. I don't know if the experience is any different in Africa, and whether Rebecca has any thoughts or comments about that.
Yeah, I haven't seen that in my own work or in, when we put together manuscripts, there's a book on albinism in Africa, and that really hasn't come up. We've had a few visits where we primarily do low vision interventions, but we'll have these large clinics where I've been retina specialists and so on to explore and examine the retina further. And obviously there can be malignancies in other parts of the eye, but specifically to the retina, we haven't found any increased occurrences of that.
Okay, thank you. So to the second question, what is the commonest type of refractive error in people living with albinism?
You can touch on Rebecca.
That is,
Yeah, go for it.
Yeah, yeah. I think in the US where I've had my clinics, the majority are that I see are farsighted, so hyperopic with astigmatism. So most common is to have an astigmatism portion to the prescription, right? And that's really more on the cornea and kind of the shape of the eye being a little more oval, probably because the lid's putting pressure on the cornea. There are different theories about that. And Dr. Thomas, is that in agreement as well about the cause of astigmatism and the common finding among albinists is more related to the nystagmus at the lids?
Yeah, I think it's really difficult to figure out causality, I would say. But the observation in terms of what you reported is quite interesting because we find also hypermetropia is much more common in the UK. And also there's publications in European populations like Danish populations, for example. They've done some nice work on the prevalence of different types of refractive errors in albinism, and they find that hypermetropia is much more common. And in terms of the type of astigmatism, it tends to be withdrawal astigmatism, as you had pointed out. But it's interesting that there's a difference in terms of the type of refractive error that you had mentioned in your talk as well, about there being more myopia in Africa, for instance. I wonder why that is, and if you had any thoughts on that.
Yeah. No, it's a good question, and it's been something for 12 or 13 years I've been wrestling with and visiting myopia groups, with research groups and understanding. So, just as a reminder, my talk, it's definitely a nearsighted prevalence, myopic shift. And when I've done one analysis where we've measured axial length, and there's a couple causes of nearsightedness, and one can be more in the cornea, one can be kind of related to the lens itself, but this is definitely the axial length where the eye just grows longer. And so we really don't know. Is it more in the equatorial regions? Is there something around, some folks have hypothesized that it is from genetic, but then you say, well, why isn't it genetic in other forms of albinism across the world? But we do know there are these clusters of a certain type of albinism in Africa, at least some of the work of Murray Brilliant and so on in the early days of where that kind of P gene originated, and maybe that work has evolved from here. I think we had a genetics talk earlier this week. So I think the answer is we don't know, but it is a big issue because you see this at 4 years old nearsightedness, and at first the nearsightedness can help because there's a prevalence. You want to bring things closer to see them enlarged, and so it can help in a way to be myopic. But then of course it makes it more blurred at distance, and the magnitude of that nearsightedness definitely changes and increases over time. And so by the time someone's 16, 20 years old, you're talking about a prescription that can be minus 16. And these powers are so high, it's very difficult to get the glasses and if you break them, to be without them once you start to learn how to use them. But it doesn't mean that if you wear the glasses that you're going to become more and more dependent on the glasses. And sometimes that's a misunderstood idea, that, okay, if I, really wear my glasses, maybe I shouldn't wear my glasses at all and it won't change. And that's not true, because I've seen people at all different ages who've never had glasses and still have very nearsighted prescriptions. So I think we have a lot of good questions here, so we could probably move on from there.
Okay, now to the third question. What glasses or sunglasses strategy is recommended for people with albinism? As their views restricted, sunglasses may be more restricting and overwhelm them.
Yeah, it's a good question. I've worked with a lot of different colors of lenses and found that either gray or a brown works very well, and it's just up to the person on what they prefer. Visually, I don't know that there's any real strong enhancement. When you wear a gray, all the colors are dampened at the same level. When you wear something in a brown or a different color, then certain colors or wavelengths are allowed through and other ones are blocked. So it really is a visual comfort. There's been a few studies over the years of which color should be best, and there really is no conclusive answer to that. So I recommend you try them on and see what you like. As far as restricting vision, I don't really see it that way. It really is, there's too much light and too much glare already for the person with albinism. And so to reduce some of that, you actually can improve visual clarity. They'll often, if you did an eye exam and you did a very bright illuminated room and a chart, and you asked them to measure vision, and then you put on sunglasses, I don't think you would have much of a difference, more than even an improvement possibly with the sunglasses, because they're reducing some of that glare. It's often called veiling glare. It kind of can blur your view a little bit. And the frames don't really restrict the view very much. That's just like anyone else. And with albinism, the good thing is you don't have field of view restrictions where you don't have tunnel vision or other field defects. And so that's a nice thing that sunglasses aren't going to get in the way of. I don't know if you want to comment further on that, Dr. Thomas.
Yeah, I think overall, glare is a big issue. With individuals with albinism, they suffer from photosensitivity or glare. And there's been some interesting work around this, looking at, is there a correlation between iris transillumination defects and the degree of glare they're experiencing, likewise fundus hypopigmentation and the amount of glare. And interestingly enough, they find that actually there isn't much of a correlation between the degree of iris transillumination, but for some reason the fundus hypopigmentation tends to correlate more with, and this again is work published by the Danish group, Line Kessel and Karen Line Kessel's group. So there certainly is a problem, and like you said, alleviating that problem is important, and using some sort of glasses that is a personal preference often for the patients as well, that works for them, tends to work. And even simple measures like using a sun hat with a wide brim just protects that overhead sun. So simple measures like that also might alleviate some of these issues.
Right. So the fourth question, what is the prevalence of foveal hypoplasia in the various subtypes of oculocutaneous albinism?
Yeah, so we did quite a lot of work around foveal morphology and foveal development in albinism, as well as related conditions. And one of the studies that we had recently published was almost like a global survey of this across multiple centers that work with albinism. And in total, in this study, there's over 900 patients or individuals with foveal hypoplasia and different genetic causes. And we found some really striking patterns emerging. So in syndromic forms of albinism, oculocutaneous albinism, such as Hermansky-Pudlak syndrome, we find that they only have very high grades of foveal hypoplasia, and almost always they have foveal hypoplasia. Similarly, with ocular albinism, which is an X-linked disorder, which is due to this gene called GPR143 variants within this gene, they also almost always have foveal hypoplasia, and they tend to have severe forms of foveal hypoplasia. Interestingly enough, carriers of the GPR143 variants, they also, so these are mums affected, so obligate carriers, they can also have subtle grades of foveal hypoplasia, not pronounced, and they don't tend to be affected in that sense, but they can get these mud splattered fundus appearances. In just the ocular cutaneous albinism, from TYR, OCA2, and so on, there is a full spectrum of foveal developmental defects we see. And there have been some reports on evident hypopigmentation, but with normal fovea in SLC45A2 variant. So there's one specific subtype that has been reported by a group in the Netherlands. So you can get instances where there is hypopigmentation of the fundus, but actually normal foveal morphology. And with hypomorphic variants in TYR, so these are variants that might have some residual tyrosinase activity, you can still get more subtle foveal defects, or even normal foveal structure for that matter. And certainly in carriers as well, we published some work on carriers. So these are looking at parents of children that have albinism, and we looked at how the foveal morphology varies. And in about a third of individuals, a third of carriers, we find that they have foveal hypoplasia. So certainly there's this full spectrum that we start seeing, but there are some specific genetic variants that we know can have more subtle features and foveal morphological characteristics.
Okay. So the fifth question, could vision worsen with epigenetic mutations on top of the existing genetic mutation?
It's an interesting question. Not something that we've necessarily explored. In theory, probably yes. Epigenetic changes could affect mRNA expression, but ultimately the underlying genetic defect has already significantly affected their vision because of arrested foveal development, for instance, or the refractive errors and so on. So that would be my sort of short answer for it. But epigenetics in albinism, I don't think anyone has specifically looked at in detail.
Okay. To the next question, could you elaborate more on how geographic disparity plays a role in vision health in persons living with albinism?
I could probably start and we can have a discussion. I mean, I think this is a very interesting question and very important one. Besides, if you just look at what we were talking about with maybe the Western and US, even Canadian and even the UK, and distributions of refractive errors and differences there, and then to Africa, and I worked with patients in East Africa, but then also in South Africa, and compared notes with some of the physicians in South Africa, and it's kind of similar. I don't have a lot of information on West Africa other than a handful of patients that have come to certain conferences and so on. But it does tend to be this myopic, and there's a few small papers that will do case studies or case series, and that does seem to hold true about this myopic versus hyperopic. I know that's refractive error, but does play quite importantly into how vision is managed, because often with hyperopic or farsighted prescriptions, doctors, whether ophthalmologists, optometrists, or whoever, might say, well, I don't know that glasses make that much difference for someone with farsightedness, because they can usually accommodate or overfocus and kind of make up for the difference of that. The astigmatism is an important thing to typically correct, but some patients, most patients, don't notice a huge difference when you put the glasses on, especially with these farsighted hyperopic astigmatism corrections. Over time, they might, adjust to that a little bit more and receive and improve vision just a little bit more. But typically, the myopic prescriptions really make a bigger difference. So when you talk about getting students in school and you talk about getting them into work situations, you want the best possible vision. And what in the Africa regions, best corrected vision with glasses on, or even in, let's say, 50% of the population who don't need glasses, because not everybody needs glasses. I found around 50% needed some kind of strong prescription glasses. And so for those folks, if you're talking about best corrected vision, they're around 2100, 2120. It's very usable vision. All we need to do is magnify things a little bit, get a little closer to the board, and real practical things. So let's say you don't have the economic fortitude to be able to, you're not parents as a child, aren't able to provide glasses and different things. You could still kind of manage your way in school for maybe 50% of the population, let's say in Africa. But then you're talking about geographic disparities around the social circles, of how they're accepted within society. And are they given the opportunity to even go to school? Are they kept out of schools because they're so different? Are there these mythical or beliefs that they're not human? And so all of that then plays into quality of life and really even into human rights issues and major traumas. So this question is huge, actually. And when you think about, someone with albinism in Western civilization, or where others around them have similar appearances, they may not stand out very much. I had a friend in a pharmacy school, colleague, who never even told anyone she had albinism, and no one even knew it. And yet she had her own visual impairment that she struggled with in all of her learning and so on, but she kept it hidden. How could you do that? So just how you incorporate or kind of fit into your community makes a big difference as well. So, I'm just I'm not talking about solutions necessarily, but just drawing out the differences of how different regions might have a very different lived experience in both your access to education and social inclusion and so on. versus somewhere else in the world.
All right. Now to the last question. Do you have good experience with blue blocker filters to manage glare? Which type of sun or glare protection works best?
Sorry, go ahead. Yeah, we talked about this a little bit with colors. I think it's important though to add on the blue blocker issue. So blue blockers, typically you're thinking about like a yellow filter, a yellow color and a lighter color. Blue blockers often can have a coating on them. So they can mean different things to people when you hear the word blue blocker. So these coatings are kind of meant to cut out some of the screen rays, you know, the reflections and some of the maybe potentially or perceived harmful things around monitors and screens. I'm not going to comment too much on that because there's, you know, some difference of opinion out there, and the scientific literature is a little bit back and forth on really the effectiveness of blue blockers and in which situation it is. But for albinism specifically, if we're just talking about reducing light so that there's not as much of this glare and sensitivity, you know, we talked about sunglasses outdoors, we talked about hats and things like that. Indoor, I find a light tint can be very nice on glasses. Again, gray or brown. The yellow is fine if that's what someone likes, but it has a funny look to it, right? Having yellow glasses makes you stand out a little bit more. And I don't know that it really visually does a lot more. People will say, I'm in low vision, we do yellow lenses quite often for folks, but you know, it's supposedly to increase contrast, but it actually doesn't increase contrast in the purest sense of it. What it does is reduce light scatter from blue and short wavelength light. And so maybe that enhances the other wavelengths a little bit more, but it's still kind of a patient preference thing. And I don't think blue blockers across the board help patients with who have albinism. And some of my patients would say it's just too much glare, like it actually feels like it's brighter when I use the blue blockers, and so not as enhancing. But just even a soft amber brownish tint indoor, a light gray, can be very soothing. But Dr. Thomas, I don't know if you have any other thoughts on blue blockers. It can be a hot topic, and people feel strongly sometimes one way or the other.
I think you've covered it quite nicely, to be honest. I don't feel particularly strongly about it. I think often we find with them it's a personal preference as well, what works for each patient. Yeah, I think I'll leave it with your comments there and your expertise on that.
All right, thank you very much, Dr.
I want to maybe just make one more comment around, you know, there's always the idea of contact lenses. Now, some folks that's not accessible. I really didn't work with contact lenses in my rural settings in Africa. But there are contact lenses that have tints on them, and there are contact lenses that have like painted iris that could kind of darken the color. So if you had a really light blue iris, then you could have kind of brown or darker. And, you know, that could block a little bit of the light that's going in. The tinted contact maybe a little bit more than just the painted iris. To Dr. Thomas's point, you know, if the issue is more about the retina and the amount of pigment in the retina as the main photosensitivity, as opposed to maybe light going through the iris and the lighter colored, then maybe just the overall, you know, basic tinted contact lens could be a fun option. But I wouldn't, you know, go and spend a lot of money doing that. Because the other issue is you have nystagmus, and so soft contact lenses can fit nicely and they can do well, but you have to have someone who can fit them on you properly, and you can go back for your visits because they're different sizes of contacts, and we would never want to jeopardize vision by putting on a contact lens that's too tight. Would never recommend you just get contacts online where you don't have a doctor or physician of some sort looking at your eye with a contact lens on to make sure it's the most healthy option. So I just wanted to mention that. You know, it can be regional specific, but always with good medical care if you're considering contacts. There are also hard contact lenses that can also help you see a little bit better kind of with that astigmatism and refractive error, but you're fitting it on a cornea that is quite oval. And so having a good fit to even a hard contact lens is critical. So again, not something that you couldn't have, especially if you have these higher prescriptions. But you just want to have someone who's very comfortable fitting the contact lens and who has actually worked with albinism and specifically with nystagmus before. And there's not a lot of those providers. You have to do some searching and find someone to work with you on those.
Yeah, I think interestingly enough, with regards to contact lenses, there have been some studies previously suggesting that contact lenses might have a role in improving nystagmus intensity, and it has a role in biofeedback and proprioception related effects on nystagmus. And there have been some publications on that, but there was a RCT done at Leicester looking at contact lenses, a randomized control trial, and interestingly enough, we didn't find a huge difference in terms of nystagmus, but in fact, most of it was probably just the fact that they were being corrected really well. And if you imagine that if they've got an anomalous head posture and they've got glasses and they're looking through the edge of the glasses or not looking through the lenses correctly, especially in individuals who might have anomalous head posture, contact lenses may benefit them because actually it covers the visual axis very nicely in compared to like certain types of glasses if it's not correctly fitted and so on. So there might be some advantage in just making sure that the refractive error is adequately corrected in individuals with anomalous head posture. And certainly in cases with anomalous head posture, surgical measures like an Anderson-Kestenbaum and shifting the null and things like that will help. It also helps with alleviating neck issues and so on. So yeah, I think that's an interesting comment regarding contact lenses, and I've had a little bit of experience with that here in Leicester.
All right, there's another question, which is
Yeah,
directed
that's a
to
great.
Dr. Thomas.
That's great. Go ahead.
Oh, sorry. It's the person is asking that he is interested in conducting research in ophthalmology. Do you have any recommendations on research directions?
That's a really good question. Always good to hear individuals interested in research and in ophthalmology as such. What I would always recommend is to reach out to your local ophthalmologist or academic unit, depending on where you are. It's sometimes can be quite challenging to start up research on your own, and it's often better to tag on to an experienced group that have the infrastructure and ability to support you develop, and also that might give you some mentorship as well locally, as you might want to go down academic ophthalmology as a route. So certainly, reach out to your local research unit. Now, what could you do yourself if you wanted to delve into research and you didn't have the appropriate infrastructure nearby? A good starting point, I would say, is doing systematic literature reviews, meta-analyses, things like that. There's lots of resources available online how you can conduct these types of literature-based research. And as you realize that there are lots of interesting trends that you'll observe in data science itself when you put things together, when you see trends, maybe global trends and so on. So it's not a bad idea to consider different options based on where you are and what you have available nearby. But my recommendation would be to try and reach out to your local unit and to try and see whether you can tag on to some of their research and then build yourself up in that direction. I don't know if Rebecca's got any other thoughts or comments.
I do. It's such a general question. It's hard to respond, specifically. Is it research in albinism or is it research in ophthalmology in general? But I would say I have my professional role is actually in research with clinical trials, globally, in fact. And so, when I'm trying to plug, let's say, an optometrist, and maybe they want to get into research, I would say, your local unit is good advice. Find someone that is doing research around you, and then go and help them on their studies. Go and volunteer, intern, paid position. So depending on what your role is, if you're an ophthalmologist and you want to do ophthalmology research, fantastic, but you need to learn how to do, take some courses online on conducting, good clinical practices. GCP courses will get you introduced to what does the clinical trial world look like? Because that's a little different than maybe doing your own lab and doing, some translational research and so on. And clinical trial work it's very interesting, and you can get involved in something larger that someone else has planned and now you're just kind of executing. But those are important skills to do before you have your own program and your own study where you have your own ideas. So you can always contact us and give us more information, and we can see if we can help connect you somewhere.
Absolutely. And yeah, I would just second and say, happy for anyone to reach out, drop us an email, and then if we can help guide you in some way, more than happy.
All right, thank you, Dr. Kammer and Dr. Thomas, for the comments and answers to those questions. So at this point, I would hand over to Akash for closing. Thank you.
On behalf of GLODERM and the Global Albinism Alliance, we'd like to thank you for participating in our webinar, and we encourage you to go to our social media platforms to learn more about upcoming events, webinars, programs, and more. Anything to add, Antoine?
Well, thank you again for joining us today. We very much hope that you've extended your knowledge about albinism through this webinar session. And we very much hope that you will now share the information and at your turn raise awareness about albinism among your colleagues and in your location. Thank you very much.
And finally, I'd just like to thank our sponsors, CeraVe, Ellis Foundation, and the International Society of Dermatology. Thank you all, and have a great rest of your week.
Thank you. Goodbye.